Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund. Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everyone, and welcome to the CATHIP Health Hour. We're delighted that, this is a real collaboration between the Caribbean African Health Network, Enfield Caribbean Association, RAFA, Croydon BME Network, Black Health Initiative in Leeds, and the Royal House RCCG, based in Sheffield. This morning, we're delighted to have a new co-host, but someone who is not new to, CAN and to our partners, and delighted to have her as a co-chair for the CATHIP steering group. So pleasure is mine to introduce you to your host for today, Dr. Vanessa Appiah. Over to you, Vanessa.
Thank you so much, Charles, and lovely to be here, everyone. So as Charles said, I'm Dr. Vanessa Appiah. I'm a consultant in sexual health and HIV. I'm based in London, and I've got the pleasure of co-hosting today. And I think today's going to be such a fantastic session. We have got Mr. Deji Olojugba, who is a vascular surgeon, and he's going to be talking about something that is really quite personal to me in terms of vascular dementia and stroke, something that unfortunately affects our communities significantly, but also thinking about how we recognize it and also how we support those that are affected. And I think it's a great opportunity for us to learn, but also to ask questions. And as we talk today, there's different ways that you can interact with us. So we've got the chat box, which I really encourage you to use as far as possible to put your questions there. And I'll make every effort to tie everything together and make sure as many questions are answered. Also, knowing some people don't feel comfortable typing, feel free to put up your hand. I ask though that just because of time, if I paraphrase or I put everything together and I cut your question a bit short, please forgive me. It's just that we want to make sure that everyone gets an opportunity to get involved as much as they can. And just so you know, we are recording today, so that this is something that can be not just we have the privilege of listening to today, but we can share to our wider community. So I think that's enough of me speaking, and I'm going to hand over to Mr. Olojugba. Welcome, and we're really looking forward to listening to you. Thank you all.
Good morning, everybody. It's a real pleasure and an honor to be able to talk to you all and as a group about vascular dementia and its relation to stroke. Just a few things. Can you hear me? If I can just have at least one thumbs up, that's great. Yeah. The other thing is, am I sharing my screen yet?
No, not yet. We can see your handsome face, but not your slides yet.
Right, okay. I've got here, thanks for that, but I've got here that the host has disabled participant screen sharing. Can I have my screen shared? Is that possible?
Yes, certainly. I think you should be made co-host. Yes, you co-host now. Apologies.
Thank you. Right. Can you see the screen now, everyone? Thank you.
Yes, we can.
Once again, it's a real honor and a pleasure of mine to be able to present this morning and have an opportunity to talk to people. I love talking to individuals, to patients, to colleagues, sharing ideas, and especially when it comes to issues of matters of where we as an ethnic minority in this country have to address our health issues. Okay, my name is Deji Olojugba. I'm a vascular consultant and I work out of the counties of Chester. I know that the audience here is from far and wide in the UK and maybe abroad. So Chester is tucked somewhere in the northwest. We are perhaps voted to be one of the nicest places to live and work in the UK, but I think that I'll leave you to that. But then we're very close to the border of North Wales, and it's got a huge cultural UK and English heritage. So I've worked there as a vascular surgeon, and I've been a vascular surgeon for many years. Just trying to see just a minute, sorry. Just a minute,
Your slide's frozen.
My slides is frozen. It shouldn't have. Just give me a minute.
No problem at all.
I am going to.
Whilst we're doing that, I can ask the audience to prepare your questions. Anything that you'd like to ask, please put it in the chat, be prepared for anything. And then as you listen, I'm sure more questions will come through as well. It's moved.
I think it's triggered on the mouse, right?
Perfect.
I qualified in so just to carry on. I qualified in Nigeria many years ago. I did all of my training in the northwest of England, and the vascular training predominantly in Liverpool. I do and have an interest in stroke prevention surgery as far as vascular surgery is concerned, and I also do manage peripheral arterial disease, which is one and the same, really, as you probably get together as the talk goes on. I have recently acquired an interest in digital health, and I will touch briefly on that towards the end of my talk. And this morning, we're going to talk a little bit about stroke and vascular dementia and the connections between the two, and how and why it's important for us, especially in our communities. We're going to see why it matters, just have a little overview of who is at risk of stroke and vascular dementia, how we recognize the signs, the treatment options available, and more importantly, prevention. And I'll end by talking a little bit about my beliefs about healthy aging. So let's start with the definitions. Stroke, broadly speaking, is a sudden loss of neurological function as a result of an interruption of blood supply to the parts of the brain. And note the word sudden there. So it's not something that happens over a period of time. Usually it's a sudden event, and it's primarily a disease that occurs or originates from the large vessels, even though it affects the brain. Conversely, vascular dementia is termed to be more of a gradual loss of brain function as a result of a chronic blood supply problem and shortage of blood supply to the brain. It occurs, as you see, over a period of time. It is a type of dementia, and as I said, it affects the smaller vessels. And there is that relationship between stroke and vascular dementia, though the etiology, that means the causes of vascular dementia, is more complex than that. And just to give a little idea, so when I'm referring to the larger blood vessels that causes strokes, for example, we're talking about these vessels here around that are the route of blood supply to the brain, and they come from the larger vessels that originate from the heart. And indeed, some strokes can be caused from clots that come from the heart or from some other areas. Comparing that to the smaller, even smaller vessels that are demonstrated here that are in the brain, and these are the vessels that get diseased in one way or form or the other and cause a degree of dementia, and in particular vascular dementia. I think it's important to identify who is at risk and what are the risk factors. And when we're talking about this, we talk about the associations of the kind of individuals that we see that end up having either stroke or vascular dementia. We all age, and there's really not much we can do about it. So, and when we often talk about risk factors, we talk about those that we can modify, those that we can change, and those that we can't change. And I think you'll all agree that we can't really change our age and as we grow older, but we can perhaps have an influence on how we age. And I'll talk briefly about that towards the end of the morning. Now, other risk factors are things like smoking, diabetes, hypertension, heart disease, in particular, heart disease that causes a rhythm change in the heart. That means that the heart is not beating at a regular rate, but rather beating erratically, and that can cause problems with things like clots that then go to from the heart or the blood vessels into the brain and cause a problem with the blood supply there. there is an association of being overweight and also an association with having high cholesterol levels in lipid levels in the blood. And that can, again, be related to things like diet and, to a certain extent, diabetes. So what causes a stroke and who's at risk? It is a problem with pipes, and I put the word there so that we can all have a kind of inclusive understanding. So the pipe may burst, in which case the blood leaks, or the pipe may get blocked and narrowed, in which case, and in either case, not enough blood is getting to the brain. And they are termed loosely as either, if it bursts, it's called a hemorrhagic stroke. I mean, hemorrhage meaning bleeding. Or if it's blocked, it's called an ischemic stroke. And ischemia in medical terms refers to an event as a result of a lack of blood supply. Now, the underlying pathology or the underlying problem with vascular disease is that our arteries all fur up. No matter how old you are, in fact, the furring process starts. And the rate at which that furring process progresses depends on some of those risk factors I just talked about in the earlier slide. So things like diabetes, things like hypertension, things like smoking, and things like aging. And what happens is that the furring builds up in the walls of the vessel, okay? And if you have some of those risk factors, they grow, the furring increases at a pace dependent on those risk factors. And sometimes it increases to such an extent that it causes a critical narrowing in the blood vessel, such that you get a state where you get a reduced blood supply to the organ, and what we're talking about here is the brain. Now, it's not just a matter of it furring up, and I sometimes, I must say, I look at my kettle sometimes and I see this kind of scaling and furring up that occurs in there, even though we wash it every day and we boil our cups of tea, and in a kind of loose way, that is roughly what happens. And again, if you look at our pipes in our houses, you get that furring up, and that's it, what happens, except that this is a dynamic and biological process. What I mean by that is that it is actually described as a form of inflammation. And when that inflammation sometimes gets angry or active, it will react. And sometimes when it reacts, it bleeds or sets up clots. And that is those are the things that cause events in the vessels that they supply. So, if, for example, the artery leading to the brain, you may have this furring up, which is causing a problem in itself, and then suddenly an event that happens and knocks off a bit of clots from this area, and it lodges in the smaller vessels of the brain and causes ischemia. Now, as a vascular surgeon, I will tell you that this narrowing of this blood vessel, this furring up, occurs once you've got it occurs generally everywhere in your body. It's just that it has not manifested yet. And when it manifests, it causes the cerebrovascular events that we all know of. So when it manifests in the heart, for example, patients get a heart attack. When it manifests in the brain, you get a stroke. Now, and how it manifests is directly related to the size of the blood vessel. So where the blood vessel is in the brain and it is a lot smaller, you will get things like the vascular dementia. Where it is larger and it causes a problem, there you get things like stroke, in a loose way. So this slide kind of demonstrates this narrowing that we see. It also, if you see the bottom here, just also shows you what happens when you get furring up of the, bleeding or hemorrhage from the vessel. The human body is never straightforward, so you can always get a mixture of these two conditions. So again, this just to describe it in a bit more detail about the types of stroke. So we have an ischemic stroke here due to a blockage in the blood vessel, which causes the term anoxia. Means lack of oxygen, and that is the end game that happens when the blood supply is interrupted. What happens is that that area dies because it is not being fed with oxygen and blood. The same happens with hemorrhagic stroke, where there's a tear in the blood vessel because the vessel is diseased for some reason or the other. And again, you've got the lack of blood supply because the blood is leaking out and causes local tissue, in this case, brain death. How does that manifest, and how do we see that on a day-to-day basis? You probably have been or heard of the word mini strokes, and these stroke syndromes have quite strict definitions. So a mini stroke, or a TIA, is an event or weakness or loss of function that as a result of an interruption to the blood supply in the brain, which is transient. So the word TIA means transient, ischemic, meaning lack of blood supply, attack, and that's TIA. And essentially, it is defined as such if it lasts less than 24 hours. Anything beyond that is termed a minor stroke. And a minor stroke is one that lasts more than 24 hours, but has not left that individual with any major disabilities. That is compared to a major stroke, where the disability is quite severe, i.e., for example, the individual can't move their arm or leg and walk, and it's lasting more than 24 hours. What you probably haven't heard about is strokes in evolution, and these are times when the brain hasn't quite decided what to do. It's trying to fight to try to recover, and yet it lapses again. So a stroke in evolution is when there's a progressive change over a very short period of time, and you can notice maybe the arm goes and then the leg goes and the speech goes as a stroke in evolution. And of course, these are medical emergencies. And as I said, it can, you've seen the adverts on the TV, and true to form, it can manifest, show itself up in the facial asymmetry, the mouth drooping, it can, or the arms being weak, or loss of vision. And again, that could be transient or could be permanent. Speech, slurring, recognition, being unable to either talk or even be understood when you're talking, can all be manifestations of a stroke. This slide just goes over this again, but to hammer home and make us as a community understand that these are true emergencies. And you may not see it for what it is when it presents. So if you see a relative or a friend or even yourself experience some of these sometimes not obvious symptoms, you do need to get it clarified by a medical professional, because often speed is of the essence when we're trying to treat stroke, when we're trying to prevent it from causing permanent damage. So suffice to say that some strokes are silent. We will not know, and it may not manifest at all. And it's only when when patients have a scan of some sort of the brain, a CT scan or MRI, that you will find that they've had a stroke at some stage in the past. We've talked about symptomatic one-sided being transient, i.e. TIA. But often one of the commonest sources of referrals to ourselves or to the stroke physicians is from the eye specialists, who say the patients come over and they've lost or experienced a transient or permanent loss of vision in one eye. So if it does happen, do not hesitate. Do get to see someone about it so they can assess whether this is truly just an eye problem or indeed is a manifestation of a stroke. We're pretty familiar with things like difficulty in speaking and facial asymmetry or loss of power or sensation in the arms. The only thing I'll say about that is, you know, it is very easy to be dismissive, very easy to be dismissive of symptoms, especially when symptoms are not very obvious. Now, the implication of a TIA, I mean a transient neurological event, is that it can be a warning sign of a major stroke. And that is why, as vascular surgeons, as stroke specialists, we are on the lookout for patients who have TIAs as warning signs. Because if ignored, there's a chance that that individual may go on and get a larger stroke, which could have otherwise been prevented if the patient had presented or treated earlier. Let's talk a little bit about vascular dementia. It is a form of dementia. And we all know about Alzheimer's, which is a leading cause or type of dementia. And vascular dementia perhaps accounts for up to about 20% of dementias. Its incidence, though, is higher amongst the ethnic minorities. Indeed, the incidence of dementia full stop is higher amongst Blacks. And we've got data both locally and reading through things across in the States, where you see that the Afro-Caribbeans and Blacks in the States have a higher incidence of vascular dementia. And indeed, this condition is said to rise in the third world countries. I think it's worthwhile considering that health inequalities play a big role in this disparity of instances beyond those of genetic, your genes, beyond race per se. I think, and so the studies will suggest that health inequalities do play a role in this disparity of incidence of vascular dementia and indeed dementia amongst the population. So now this is where we link strokes and vascular dementia. It's not a true or unique link in that there are several reasons that have been offered for causes of vascular dementia. And you remember I spoke about the furring up of the arteries. And whilst in strokes and other conditions, it's in the larger arteries, in vascular dementia, it is in the smaller arteries, those ones at the periphery that you see all around here. That's where the disease is. However, when we talk about multi-infarct vascular dementia and single infarct vascular dementia, that means, infarct means death of a tissue. So what they're saying is that, is this vascular dementia as a result of a single event, an area of dead or compromised brain, okay? Or is it as a result of repeated infarcts or areas or small areas generalizing around the brain, which is not working well? Okay, so that's the difference between a multi, which is several areas, or single, which is just one defined area. And there are those links between these infarcts. And the infarct will occur when a patient has had a stroke, and hence the link between the stroke and the vascular dementia. But I do stress that there's a lot more to vascular dementia than just that association between stroke and vascular dementia. Now, this is a study from the Rothwell group in Oxford, and what they were looking at here is what I'm trying to explain. And what they're looking at is the prevalence of dementia and perhaps vascular dementia with and its relation to the degree of strokes. So I'm not sure whether you can make out the color coding here, but I'll just take you through this study. So the NIHSS is a scoring system for severities of strokes. And obviously the higher you go, the more severe or profound the effect of the stroke is. So at one end, you have a patient that's had a TIA, i.e. the event has been quite transient and they've forgotten about it. Or more than 10, it goes up to about 15, in which case they've had an established stroke, loss of significant disability. And what this shows is that for a patient, for example, I hope you can follow the arrow, who has had a TIA, the risk of them developing a dementia or prevalence of dementia is relatively low. You know, we're talking about 10, cumulative incidence of 10%, right? Compare that to someone who has an NIHSS score of more than 10 up here. The risk of dementia is quite high. That's part of the evidence that links vascular dementia with strokes. Let's talk a little bit about the risk factors for vascular dementia. And I think it's worthwhile talking a little bit more about this and noting that there are slight differences between those factors that relate to stroke and those factors that relate to vascular dementia. There's a significant overlap, as you know. We talked about age, we talked about hypertension, we talked about diabetes, smoking, alcohol. Some of the studies suggest sleep apnea, okay? And this is because it causes kind of prolonged episodes of hypoxia. Hypoxia meaning lack of blood. Anoxia meaning no blood at all. And hypoxia means reduced amount of blood. Frailty, head trauma, and atrial fibrillation. For those who haven't heard about atrial fibrillation, that is very much an irregular heart, which, because it is not beating regularly and efficiently, it can cause clots or small clots to detach from the heart and move into the smaller vessels of the brain. And what happens is that this happens as very small segments or small clots over a prolonged period of time. And they will then cause what we call microemboli, meaning very, very small clots in very, very small vessels. Now, I'd just like to highlight, not necessarily uniquely, but importantly, the association between hypertension, and stroke and vascular dementia. And hypertension is rife in our society. It's rife in our communities, especially Black communities. Probably almost a twofold difference between ourselves and maybe the Caucasian communities, as is diabetes. Hypertension or lack of control of hypertension is directly associated with vascular dementia. So when we start talking about what can we do and how do we modify this, we know that we all want to age, so we want to get older. But if you do have hypertension, that is in our giving to try and control. The same with diabetes, and the same with lifestyle things such as smoking, alcohol. The development of dementia of any form can be quite distressful for the individual and for the families who have to cope and try and get their head around why someone who's otherwise physically able is having symptoms. Now, recognizing these may not be that straightforward, but the early signs of vascular dementia is no different from that of dementia in general. Problems because it is a mixture of the kind of problems with cognition, kind of ability to remember and do things. So early on, you get problems with organizing and planning, difficulties in following a series steps of instructions, slower speed of thought, and problems with concentrating. later on, it can evolve to problems with recalling things, memory loss, language, and visual spatial skills. So if you had games and things that you're used to, you suddenly find that you're struggling to do them. And this could also lead to mood changes and anxiety. So later symptoms of vascular dementia would lead to things like confusion, disorientation, memory loss, mood changes, delusions, and hallucinations, and ultimately the inability of that individual to self-care. And, I've seen it, and I'm sure a lot of people have seen how devastating this lack of independence and this deterioration can have on an individual and their family. So beyond that, why does this actually matter in our communities? Why are we talking about it beyond the fact that these things exist, and and what should we be doing about it? As I've alluded, it does cause it has a significant incidence in our family, in our community. But not only that, it is a leading cause of death. So this slide is taken from the ONS, the Office of National Statistics, and it looks at death in males. I think this is 2021. I can't remember exactly, but it does look at causes of death in males per 100,000 in the UK. So this is local figures. And as you can see, and as I've kind of encircled here, in the males to start off with, behind ischemic heart disease, dementia and Alzheimer's disease is a leading cause of death across the populations, and in the Black Africans, and in the Black Caribbeans. Okay. And indeed, if you look at the Black Caribbean there, you see it's almost, well, it is in fact more prevalent as a cause of death than ischemic heart disease. Ischemic heart disease meaning things like heart attacks, meaning things like heart failure, but predominantly heart attacks. Okay, so there you go, that in males at least, beyond cancers and things, that the problem of dementia and Alzheimer's disease and vascular dementia is a leading cause of death. So what about women? So again, commonest cause, but even in women, you find that above that dementia and Alzheimer's disease grouped together here, not necessarily for vascular dementia, but vascular dementia, as you know, is in there, is a leading cause of death. And check out this figure, ischemic heart disease there is 63.6%. Dementia and Alzheimer's is 120. It is therefore a problem, and therefore something that we should all take notice of and see how we can draw steps to reduce the incidence and causes of this death. As we all grow old, we have changes in what we can and cannot do. And there is that line between what healthy aging is and what actual healthy aging isn't. So it's acceptable that as we grow older, we have a slower pace of thinking. We're probably more hesitant in what we do. We can associate the person, but not necessarily the name. And we, pause when we find words or reminded of the past. That's not necessarily abnormal, but you would notice that if you can't think the same or can't do things like before, can't get started, these are reflective of cognitive changes which may need referral to assessment of dementia, and in fact vascular dementia. So what can we do? There are no specific drugs for vascular dementia, though whilst there are drugs for Alzheimer's, there are no specific drugs in use specifically for vascular dementia. If someone has vascular dementia, there's general things that they can and should perhaps do. And this is about maintaining normality as much as possible, because disruption of the normality will cause and can cause a stepwise deterioration in, in the mental state, cognitive state, and the disease process in general. So it sounds quite basic, but keeping hydrated, we see as young people, the younger people rather, they have these kegs of water they're carrying around and drinking. For someone who, has memory issues, has cognitive issues, the last thing they don't think about keeping hydrated, they don't think about drinking. They don't, their diets may end up making them more constipated. And because they don't drink, they don't eat well, they get associated problems such as urinary problems, urinary stasis and infections. Urinary tract infections is a very common reason why patients get admitted to hospital. And in this day of age of the COVID pandemic and other viral infections, it's important that patients don't succumb to viral infections, flu, pneumonia, or COVID. But there are more aggressive things that we can do to reduce the risk of developing vascular dementia in general. So, talking about lifestyle changes, talking about dietary changes, I've talked about managing healthy conditions, exercise, especially cognitive exercises, and embracing technology. And I'll go through these one by one as much as I can. Now, you remember the list of conditions such as hypertension, diabetes, increased lipids, hyperlipidemia, that is, we said were related or risk factors. They can, in the most, be managed, controlled, not necessarily cured, but treated. So for increased cholesterol, for example, we have statins, which, though they have had a bad press, and though not everybody may benefit from it, it is definitely a leading tool in the combat against vascular disease in general and vascular dementia specifically. Blood pressure tablets and blood pressure control is important. The prevalence of hypertension in our communities is very high. It is shockingly high. Okay, so, and again, there are medications that we can use to treat them. The problem with the medications is compliance, and I would urge that, it's important to be as compliant as possible, because often patients need more than one tablet or one antihypertensive to reduce and control their blood pressure. But the longer that blood pressure is under control, it reduces the risks of untoward effects from hypertension. A lot of patients will be prescribed antiplatelets. These are drugs such as aspirin, which reduce the chances of clots developing. Now, just to illustrate how this works, when I said that the furring up is a dynamic process in the vessels, things like statins, things like the aspirins, they reduce, for the lack of a better word, they reduce that inflammatory process and reduce the incidences of the artery becoming angry, so to speak. Some patients may need anticoagulants, and that occurs, for example, in patients who have a rapid heart, irregular heart, the so-called atrial fibrillation, as we mentioned before. And there are other drugs that control heart rates. Diabetes, again, is rife in our communities. And apart from the daily control of the blood sugars, it's important that diabetic control is used, because that can slow down the process of hardening of the blood vessels, which if left, untreated, can then lead to complications from not just diabetes, but in certain things of strokes and vascular dementia and dementia in general. Now, I can't leave or present this without plugging in what I do day in and day out for a living, and this is what I do. And this is my role in preventing or reducing stroke, this instance of stroke. So noting that there is a link between stroke and vascular dementia, I and vascular surgeons, we tend to operate on patients who've got index lesions in their carotid arteries. And what I mean by that is that one cause of stroke is a focal or localized area of narrowing in the blood vessels that lead to the brain. And that can cause a stroke if that area either blocks off or erupts. And what vascular surgeons do is that they clean out that area, just like you clean out a blocked drain pipe. And that operation is quite a common operation, and it's meant to reduce the chances of any individual who's at high risk of getting a stroke from getting a stroke. And however, studies have to tell us, and longitudinal studies have to tell us whether it changes the onset of vascular dementia or not. But it probably does improve cognition, and it does reduce the chances of stroke. Talk a little bit about lifestyle, and I think this is important as we all are aging and getting older. There are certain lifestyles that we need to embrace and certain lifestyles that we need to avoid. So the filling up of the arteries, apart from things like age and the other things that I've talked about, smoking has a strong association with the condition of atherosclerosis. Atherosclerosis is that filling of the artery that I mentioned. What about diet? And I think this is important. There are certain diets in our cultures which may not be as healthy as we think they are. Whilst they are favorites and we like them, they're probably laden with salt and carbohydrates, which we know are not good for us. Things like the Mediterranean diet, or diets that have quite a healthy amount of fish and fish oils, have been associated with a reduced risk of stroke and dementia. And it's worthwhile reading up about this and taking a view. We should not underestimate the role of exercise. Both physical exercise and cognitive exercise reduces our chances of getting a stroke or vascular dementia. Okay. There are studies which do positively associate exercise in whatever age group with a reduction in incidence of strokes and vascular dementia. Now, I mentioned hydration there. And again, it's one of those things, as basic as it seems, that we should have as a conscious effort to keep hydrated on a daily basis. Coming towards the end of this talk about, and in this day and age of information technology, the digital world, there are lots of things out there that we can use to enhance our cerebral reserve. So even though you're retired does not mean that you can't continue to learn. Card games, mental maths, puzzle maths, studying, learning new language, maybe go on a PlayStation. These are things that will keep our brains stimulated. Now, if you ask me, it is not entirely clear whether this would, and I'm definitely not saying that this will prevent you getting vascular dementia, but what it does, it increases the cerebral reserve such that you've got things to call upon in the event of cognitive decline of one sort or the other. And there are lots of apps online for online learning. There are Fitbits for our exercises, and there are lots of apps that tell us all sorts of things. But we do need to be careful that whatever app you use has to have the right information and has to be, in some respects, certified. So the NHS apps, for example, are perhaps safer than a lot of the commercial apps out there that may sometimes provide misleading information. So let's define that we are all growing older, understanding what healthy aging is, that we can age and we may acquire one condition or the other. And healthy aging is how we coexist with that condition such that we can maintain functional ability and still have well-being into our older age. So healthy aging does not mean living free of all health issues, but managing them best with a view of living the most independent life that we can do in old age. I finished by just leaving some resources here because the information is out there, okay? And for us to look at, for us to embrace and to use in our fight towards both achieving health equality and reducing the risk of conditions such as stroke and vascular dementia in our societies. Thank you very much for listening. I've come to the end of my talk and I'm quite happy to take some questions.
Oh, thank you so much. It's been echoed in the chat, but something I just want to highlight is that you've made a really complex subject just so digestible, and it's been great revision for me, but I'm sure people on the call will really benefit for how you've just laid everything out so clearly and demystified. So first of all, just a huge massive thank you. Yes, and you're getting lots of praise in terms of excellent presentation. So I'll sum up some of the things at the end because you've given some real gems there, I have to say, that I think is great learning for all of us. But I'm just going to go straight to the questions. And again, thank you to everyone. It's been really interactive. And again, I think it's reflective of how you've been speaking. But I'll start with the first question. So the first question is, can you have a stroke and vascular dementia at the same time?
Yes, the answer to that is definitely yes, you can have both coexisting. Yes, and I did try to make it, I just do need to stress that the relationship between stroke and vascular dementia is very complex. We're still trying to understand where the lines lie. And people can have both vascular dementia and Alzheimer's together because it is at the underlying is an aging process. So, when I'm talking about the risk factors, I put right there on top age, and we all kind of wear and tear as we grow older. But yes, the answer to that is yes, you can have them existing together.
Great. And I think it's been mentioned before, but if you have a mini stroke, is this an early indicator that there may be something more serious beginning to happen?
Yes. And that has been extensively researched, and it is practiced all over the world that if you've had a mini stroke, that we need to explore the risks of that being a warning sign of a more major stroke. And there's data that actually quantifies or tries to quantify what that risk will be in 12 months. And usually, they will say that is in the order of about 15 to 20% chance of that individual, depending on the cause, getting a major stroke in the next 12 months. And I tell my patients, because obviously, from you come to a clinic, let's say, for example, you've had a TIA in your eye or your arm, and you come to the clinic, it happened a week or so ago, you feel fine now, and then suddenly a surgeon is telling you need an operation that could cause a stroke in itself. So there's a lot of education that has to go behind that, and counseling and reassurance. But hopefully, if anyone finds themselves in that position, or you are with relatives that have that in that position, yes, they do need to understand and be spoken to and be reassured as to the process and the indication in that particular case of going on to have an operation if it's needed, or just remaining on tablets to reduce that stroke risk moving forward.
I think you've highlighted something so important in terms of, and it's actually the responsibilities of medics and healthcare professionals to make sure that the information that we impart is clear, and that we're clear about the indication, because there are so many things that do make things quite complex to understand. And you're thinking, why am I going into something that now could cause me a stroke? And so trying to decipher that and understand that can be difficult. So completely agree. And I think Ngozi on the chat, thank you for sharing. So Ngozi says that she suspects that her mum had vascular dementia, and I'm sorry to say that her mum passed away in 2019. So Ngozi, we're sorry to hear that. But Ngozi asks, when you have vascular dementia and stop talking, can you still understand what people say to you? Because her mum stopped talking, but she could understand everything.
That's an interesting one. Now, I'm not a stroke specialist. I am a vascular surgeon. Now, but the manifestations of vascular dementia can be quite broad, and a lot depends on whether there was a stroke element in addition to that, because the stroke element in itself can cause what we call aphasia. I mean, you can understand what people are saying, but you can't speak, and that can often be that can be a feature of the stroke in itself, not necessarily vascular dementia, but a stroke in itself.
Yeah. Okay, thank you. And there's some questions about some of the stats that you presented and just understanding the rationale for it. So one of the questions was, is the disparity of incidence across all age groups? So when we see it in more in Black communities, is that across all age groups?
Usually they don't break them down by age groups. And that particular one is all ages, all in. So it has not broken it down by age. And I think the issue with things like vascular dementia and dementia in general is because it's an aging process, the granularity of data for the younger patients will be a lot less, because they're fewer for in that younger age group. So it is in terms of the data, the underlying data, an all cause for across all age groups.
Great.
But
And
with the tendency towards the older age groups, because that's where the population at risk is.
Great. And related to that, so I'm reinforcing just understanding why we do see it more. So the question is, why is dementia so much more in older Black people? Why do you think that is?
Yeah, and that goes back to the risk factors, and that goes and I need to drive that point home, that the risk factors, the hypertension, the diabetes, in particular, are higher amongst the Black people, and therefore the fallout of those conditions, such in things like strokes, in things like vascular dementia, is a manifestation of that. And then one wonders whether the management of those conditions is poor, not just because of the incidence, but also because of the inequalities that exist. And so if we start to address those inequalities, things like access to health, things like health education, things like screening, and modifying that towards our population, maybe we can then start having inroads into reducing that disparity. So that the disparity starts at the grassroots in terms of the disparity of the risk factors, or prevalence of risk factors.
Yeah, it's so true when you listen to it, because it's all that domino effect. One leads to another, and we've got to kind of go back upstream and stop and eradicate those disparities of the impact all our issues of access and engagement and uptake, to then see a difference later on. And I think there are some questions coming up about prevention, which I'll go to, but just one more question about the stats. Someone wanted you, if you could kindly clarify some of the stats presented. So they say that it seems that there's a much higher incidence of dementia as a cause of death for white people than Black people. But from what you said earlier, the incidence of dementia is higher amongst Black populations. Does that mean we are more likely to get dementia, but not as likely to die from it? I'm
not sure about that. Let me try and go back to the slide there. I think the causes, the cause, if you talk about the multicolored slide and that I presented there from the Oxford group, the incidence of death in Black people, of dementia causing death in Black people was higher than in the Caucasian population.
Fine. So I think it's just, so we're seeing an increased incidence of dementia, and also we're seeing an increased risk of death as well.
Yes, dementia-related death.
Great. Okay.
Well,
So no, thank you so much for clarifying. And I'm just going to call in someone that's got their hand up. We've got a lot more questions in the chat, so if we haven't answered, I haven't forgotten you at all. But just to ask, we've got Michaela Clark with her hand up. So I'm just wanted to see if she'd like to speak. Apologies if I pronounced your name wrong. Michaela, if you still want to answer.
Yes.
Oh, perfect. Thank
Hello.
you.
Sorry. Hello. Great talk. Thank you so much for your talk today. I wanted to ask, just touch upon diet. You mentioned that a fish diet, introduction of fish into a diet can aid prevention against dementia. What about plant-based and vegan diets? Is that something that can be can actually also aid as prevention or not?
I think when we're looking at the facts of diet, really, it is about the proper balance of carbohydrates, salts, and lipids or fats in the diet. And my view about diets is that it depends on who's pushing the agenda in relation to a particular diet, because there are often industry behind that who are not necessarily in the best interest of the patients, but rather pushing a particular agenda. To my knowledge, there's no clear advantage pushing either vegan or plant-based in terms of the risk of reducing dementia of any form, to my knowledge. There are studies on fish, particularly because of the omega oil amounts in that, and that is perhaps more published and perhaps more recognized. And beyond that, there are studies that look at population diet in certain populations, the Japanese, for example, the Mediterraneans, for example, and look at what they eat and look at the incidence of various factors in their life, in that population, and also the longevity that's associated with certain diets. And that's where a lot of that comes from. So interpreting it and recommending it is a bit of a minefield. But more importantly, the underlying thing is the correct balance of carbohydrates, protein, and fat, and salt.
Okay, thank you so much.
Thank you. And I'll just go back to some of the questions in the chat. I have to say they're coming thick and fast. So, but we're thanking everyone for their engagement. I wanted to highlight a question from Judy. And Judy, we're really sorry to hear this. Judy on the chat has said that her mum unfortunately had a stroke last week, but it was caught early and she was given an injection and was just discharged within 4 days. She's now on aspirin and furosemide, and she's asking, is it likely that she can have a major stroke later?
So the management of strokes in this country is pretty uniform and pretty standard. Okay, and so it'll seem, without going into the details, that she's gone through all the right steps. Mm-hmm. So the injection most likely is what we call a thrombolytic, and a thrombolytic is an agent that dissolves clots. So she must have had a scan, and she must have been caught or taken to hospital early enough. And you know, in my slide there, I did mention it being a medical emergency. Mm-hmm. And why it's a medical emergency is that there's a little window when certain treatments can be given, especially thrombolytic treatment and therapy. So it seems that, you know, your mum got into hospital on time, in time to be able to meet the criteria for the clot busting agent and she was given that injection, she would have had further scans to see where the cause or source of this clot is. And again, referring back to the slide, I did mention it can come from the heart or it can come from that vessel in the neck. And they would have decided whether she needed surgery or not. And on that basis, started her on the aspirin. Now, coming back to the biology of things, the role of things like the aspirin, and I hope she's also on statins, which is, I know you didn't mention that, but you probably wouldn't know, but she probably is on a statin, is that it reduces those risks almost close back to baseline, okay? Baseline meaning that of the normal population. So yes, I think that, so in terms of, so it's about risk reduction, and it will seem that they've put all the things in place, just make sure that she's also on a statin, which I probably believe she's on, and those would be the main factors, in addition to blood pressure control, that will reduce her risk back to baseline.
Great. Okay. Thank you so much. And a related question, just about understanding about some of the meds. So could you explain what the difference between an antiplatelet and anticoagulant?
So they are, an antiplatelet does, its effect is on the platelets. Now, platelets are gifts from the Almighty to stop us from bleeding to death. So they kind of little cells, part of our blood, that clump together and stop and cause and start the process of clotting. But they are cells. And so what an antiplatelet does is that it kind of reduces the potency of these cells to clot. And therefore, when you have, let's say you have a narrowing in your vessel, and like I said, it's a dynamic process. That narrowing ruptures and it starts to bleed. What will happen is that you get a clot around it, and that clot may travel to the brain and cause a stroke. So the antiplatelets reduce the chances of that clot developing, and therefore the side effect will be bleeding, but means that that clot will not develop and be able to progress. Now, a anticoagulant works on the pathway of clotting. So slightly different. It doesn't work on the cell wall or the platelet wall. It works on the pathway of clotting. And there's several anticoagulants and several ways that they work. But that the whole clotting process is a pathway of several enzymes that interact to cause the clotting, and that's where anticoagulants work. So they work quite differently. However, I would say that the anticoagulants are more potent at stopping clotting than antiplatelets.
Thank you so much. And I think the next question is there a typical timescale from the onset of initial symptoms to the advanced symptoms and deterioration? So just about natural.
A natural history of vascular
dementia.
It's a timescale. It can be, I don't think there's any prescribed timescale. It can go on for years. Depending on how it's managed, depending on the severity, depending on the burden of, ischemia or neuronal and cerebral compromise. It could depend on that.
Okay, thank you. And then there's quite a few questions that are directly related, so I'm just going to say them together, but it all comes to really about prevention and reinforcing what you've been saying about how to slow the process down. So some people have asked about, can the furring of the arteries be reversed or delayed? What can the patient do to clean the arteries themselves? So prevention, and also related to that, someone has asked for a plea for you to re-emphasize about exercise and the importance that plays in it. So I think there are a number of questions about slowing the process down or reversing it, and how that can be, how they can do that.
I think in our modern society, there is no single pill that would, or or method that we can use to reverse it or even slow it down. But a combination of things can help to manage it. And those combinations range from things that an individual does to things that, for example, medics do. Okay, so on that scale of things that medics do as a vascular surgeon, we can core out the troublesome or index lesions. As you could see in one of the slides there, we removed that narrowing because it was causing a problem. And there are some places that are accessible in the body, especially in the neck arteries, that we can access and either remove or widen that narrowing in very crude terms. From a patient's perspective, it is dependent on the individual. So if you have those risk factors like hypertension, like diabetes, like high cholesterol, or habits such as smoking or alcohol, then those are modifiable risk factors that one has to address to slow down the process. Take diabetes, for example. We do know that diabetes in itself causes hardening of the arteries and furring up of the arteries in its own special way. So the longer your glucose is under control, the lesser the chances of those arteries hardening up or that process of hardening up being accelerated. That is the theory. Now, studies would say that the impact of those kind of risk factor controls is debatable, but overarching, I think it's about being realistic as to the fact that you're going to control your blood pressure to even reduce the risk by 10%, for example. It's a cumulative thing. If you're young and healthy, then, and I think actually that the younger population, I think in general, have a more healthier aware lifestyle than the preceding generations, if I may say. So they all have their apps, they all have their watches, they're all exercising, they're all drinking, okay? And maybe what we'll then see is a longevity of individuals living into their hundreds and living what I would call healthy aging, not just because they can manage their symptoms, but also because they develop less of those risk factor issues. So it is a combination.
And I think there's a question that I'm not doing it full justice because it's longer, but it was just about asking about the genetics and how genetics plays a part in this.
I think that's a very good and interesting question. And I can't say I can answer it in full because the genes underlying, there are certain genes that underlie accelerated atherosclerosis. So when you look at certain families, for example, I think if there are index vascular events at a relatively young age, or someone has high lipids, for example, at a relatively young age, you will find if you trace that through the family that a lot of family members may have had a similar index events like strokes when they're younger, and we're saying sub 50, below the age of 50, and there probably may well be a genetic link underlying that stream of events. Now, when you have that as the underlying cause or risk factor, you will find that that's probably more difficult to control. You'll find out that that those individuals and those families develop those vascular events, be they stroke, be they heart attacks at the younger ages. And what I tell patients that are in that category is that, they can't afford to pile up any other risk factors. So you can't afford to smoke when you know that, in your family, for example, you have, individuals who had strokes when they were 50s or heart attacks when they were in their 40s or 50s. So again, it is risk reduction, but yes, that's a good question about genetic risk factors, which does play a big role.
Great. And Val and Pamela, I'm going to come on to you just as we close. I just, I can see.
I just looked at the chat. They said the younger generation eats too much fried chicken and fast food.
I love it. Wonderful. But just wanted to pull some questions together, which is just about those that are helping to look after people that have had a stroke. So how do you help someone who's with stroke to walk and talk? And it's been highlighted that there's a member of their group that has got dementia at quite a young age, at 50, and a woman at 90 who couldn't speak, but her children brought her to the group and was, bringing her in to smile, and she was trying to communicate, but while she was at home, she was silent. So I think I'm sure people want to just hear a tiny bit about managing people and supporting them.
I'm going to go to extreme here and say that, we live in an information and infotech world. It doesn't all, there are hard parts to the caring, for example, to patients who can't self-care because of advanced dementia or got disabling strokes. But there are kind of technological options, and at a very low level, just what you described there, things that will stimulate those individuals visually, by auditory means, those can all help in maintaining or preserving whatever cognitive defects and that they may have. So I would suggest that in addition to the hard work, that they do, that they embrace as much technology is as possible.
Great.
And also, one great thing about chronic conditions is there are a lot of self-help groups, there are a lot of forums that you can attach to and give ideas and get ideas from, and I would encourage that. So it's not just a lonely journey that it otherwise can be.
No, I think you're so right about that. It can be a really lonely journey as we care for anyone with whether it's a short-term or a longer-term condition. And I'm sure that colleagues in Khan will put in the chat some of the support that's available through Khan and our partners that are on through CATHIP. So I'm just going to bring in Pamela, who's been waiting patiently. Pamela, I'm really mindful because we've got 1 minute, and I'm sure I'll be told off that I have to close everything soon. But it's been such a great discussion. Pamela? Or maybe Pamela's not been able to speak. And I know, Val, you had your hand up. I did want to give you a chance.
I had to wait for you. So I had to wait for someone to unmute me.
Oh, sorry, Pam.
First of all, thank you so much. It was brilliant. I was going to do housework and then I stopped to just listen to you. And I'm so glad that I stopped the housework to listen to you. So it was absolutely brilliant. But my question is, I recently read some papers that was research with Professor Hilary Beckles, which is at the University of West Indies. And he was talking about hypertension and diabetes that happens predominantly around the Caribbean community. But what was really great was your statistics where you showed that 142 white British had vascular, and the Caribbean people had 121. And when you looked at the figures in between, the African community and the other communities were a lot less, almost half. Now, Professor Beckles believes that the genes, because of slavery involvement, contributes to why certain illnesses affect people from the Caribbean, and that was why the question about genetics played an important part, because it is a great difference between, say, although we're all black, between what happens to the African person and what happens within the Caribbean person. And the only thing that we've got that's really different is the fact, because of slavery, the Caribbean genes are not as pure as, say, the African genes are. And I just listened to something yesterday again about that. So I just wanted to know how much research has been done in this country to look at those genetics, and because we're such a minority group, is any energy being put into looking at the genetics, say, of a group like the Caribbean community, because that's now changing with the number of mixed race relationships that's actually happening, which means that you're going to see other things happening. So I've just been researching that because I run the Caribbean Social Forum, and our youngest member was 50 that has dementia, and we had nothing ready for her, but we had things ready for the older person, but we had nothing ready for someone young. And so now we're working on something to help with the younger person that's got dementia as well. So big question, but thank you so much for today.
Thank you. Unpicking that, I think, is the crux of how we get down to granular issues regarding, the Afro-Caribbean community, the diseases and the disparities. And like you highlighted, it's not just about perhaps inequalities. Are there other things, are there other biological things that have not been explored? As far as I know, if they are going to be explored, studies from America are often the leading areas that provide that kind of data and research. We're still very much in the mix of the general population here, and put in the same basket as ethnic minorities and things. But I believe that will change. I believe that there will be a reason to research, again, leading from the inequalities. Once we've answered the issues around inequalities, that they can then start focusing on the genetics and the familial aspects of that disease disparity. But I think, yes, it is something that needs to and should be done.
Thank you. And our very, very last question, because I know there's someone called Zoom user who has her hand up. And I just want to give you a chance, but if you could unmute.
Okay, I'm so
go.
sorry. I've had my hand up, but maybe I'm using my phone, so you maybe can't see me.
Yeah, I didn't see, but someone kindly signposted to you. So you have the floor for the last question.
Okay, well, I'm going to, I won't be long. I'm sidetracking to the pharmacology, statins. There are people who has never had diabetes and it's not genetic. And when they start to take statins, they develop diabetes. I don't know if the doctor has any information or clarification on that, because it actually states in the information on the statins that if you take statins, you can develop diabetes, even if it's not a genetic thing.
Yeah. So there is an association between statins and developing side effects. Some of those side effects may be metabolic side effects, things like diabetes, for example. And for the individual that's affecting, that is quite a big thing. But I think the medical kind of front would want to not use that as a deterrent against using statins, because we believe there's an overall benefit. But every person that is prescribed diabetes must be treated as an individual. That is prescribed statins, rather, must be treated as an individual, because there are patients who develop side effects. Some they are in the minority, I must say, but therefore at that individual, it is a big thing. So it ranges from abnormalities in the way of liver functions to things like diabetes, to the more common side effects such as muscle pains. And those are reasons why some people stop using statins.
Can I also ask, Benicol, is that sort of relevant to statins? Would that be helpful?
Benicol.
But they
butter.
say if you take,
the butter?
Drink. Pardon?
You mean the butter, Benicol?
No, the drink, Benicol.
Oh, the drink. Okay.
Yeah.
Yeah. I don't know the answer to that, to be honest with you. Benicol is, I've seen Benicol. That's a drink, isn't it? It's
they say it reduces your statins, down
your cholesterol levels.
Your cholesterol. Sorry,
I'm very skeptical of such claims, and often when they do that, it's a small population, and when they do that, the devil's in the detail, so to speak, in terms of the benefits may be marginal. But a commercial organization may well say 5% or 2% reduction is a significant thing. And then for you to achieve those reductions, you may need to drink quite a lot of Benicol.
Anyway, thank you very much. And your presentation was absolutely spot on. Content good, organization good. Well done. I'm very proud of your doc.
Oh, I love it. Zoom user. I don't know your name, but it's called Zoom
Amy,
user.
my name is Amy.
Amy, well, thank you. You've kind of tied it all together for me there, because I just and I think we've covered most questions as much as we can, and I have been. Thank you for indulging us for 6 more minutes for this, but I think I just have to thank Mr. Deji again. You've been absolutely fantastic, and it's been resonant of the questions that have come through, and the fact that so many people have come online, and I think people must have called their friends to come online after hearing early parts of your presentation. So thank you so much. And there are a couple of key things that you were saying, and the key thing about the fact of strokes in evolution just being a medical emergency, and so not sitting on the symptoms. If you see it in yourself or someone close to you, don't sit there, go and seek help so that interventions can be put in place. And the other thing, 2 other things was so simple about hydration and water. We forget that, but it's such a crucial part of looking after ourselves. But a line you said near the end was, you can't afford to pile up any other risk factors. So once you know that something is in your life, it's about trying to take things to minimize those and stopping any new ones coming into play, giving yourself the best chance of aging well. So thank you so much. And I'm just going to hand over to Charles to end things today. But thank you.
Thank you.
Great. Thanks, Dr. Vanessa Pia, for hosting, and to Mr. Deji, for coming on. And we're delighted that Dr. Deji will be also leading on our digital health, clinical side of things. I'm going to hand over to our amazing chair, Dr. Faye Bruce, who will tell us what we have planned for March, which is dedicated to women's health. So over to you, Faye.
Thanks, Charles. So again, a massive thank you to Deji. That was amazing. It's always great to speak about these issues that are so prevalent in our communities and to do it so well. So thank you so much. And Vanessa, thank you so much for hosting so brilliantly and getting through all those questions. So thank you for that. So yeah, we've got a huge well, a lot in store for you for March, a very exciting month. We know it's International Women's Day in March, March the 8th. We also know it's Mother's Day. I think it's the 11th of March as well. So it's all about women for March at Khan and our partners. So we've got a lot in store for you. The flyers in the chat box, and all of these topics have been selected because they're prevalent in our communities, and we've got some fantastic consultants and doctors that will be taking us through things like fibroids and endometriosis. That will happen on the 5th of March, so next Saturday. Please join in. Same Zoom link. We're going to be talking about preconception, perinatal infections and sexual health with Vanessa. Is going to be taking that session for us as a consultant gynecologist, so in sexual health. And then the week after, we're going to be talking about causes of pelvic pain. So again, kind of linked to endometriosis, but there's lots of other reasons why we get pelvic pain. So we're going to take you through those. And the final week, we've got our consultant in obstetrics and gynecology, Dr. Karen Joash, who's going to talk about polycystic ovarian syndrome. Again, many of these conditions prevalent in our communities, not very often talked about, not very often understood, but we're going to really look at how we can educate, empower for the whole of March, all about women. So thank you, and back to Charles.
Great. So thanks, everyone. If you'd like copies of, the slides for today, then by all means, drop us an email, health@khan.org.uk. If there are any topics you would want us to consider, then, let us know as well. But we're really grateful to all of you. Keep tuning in. It's the same link, and great to be working with partners, Enfield Caribbean Association, Clotting BME Forum, the Black Health Initiatives in Leeds, RAFA based in Birmingham, but working across the country, and then the Royal House, RCCG in Sheffield. this has been organized for yourselves, and, make sure you maximize it. Let us know what you want us to, topics you want us to treat. And in between the sessions, if there are any issues at all, we try and get commitment from our doctors to provide free consultation or second opinion, on a free basis. It's, so please, and if you know any consultants or any Caribbean African doctors who you feel will want to support this, by all means, let us have their details, and then we will touch base with them. This has been live streamed. It's available on YouTube. It's available on Facebook as well. Share the link. Look after yourselves. Yes, we know the COVID restrictions have ended, but please look after yourself. Keep safe. Follow the previous guidelines, which are still relevant because we're living with COVID. And, let's look after each other. So massive thanks once again. Have a wonderful weekend. Look after yourselves. Invite someone along next week. Come to International Women's Day looking at preconception care, miscarriages, and the impact on mental health on the 8th of March as well. Have a wonderful weekend, and God bless.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.